Thank you. I'm really pleased to have the opportunity to present this work at this forum. It's not quite the same form of peer support that I'm going to talk about that Nan's just been talking about. Just to clarify that in this presentation, the peer support I want to refer to is more person with dementia to person with dementia, or active family carer to active family carer. There were in these services volunteers involved, more often in a facilitative sort of way. So slightly different meaning to the purpose of peer support. The National Dementia Strategy for England placed considerable emphasis on peer support, actually. It had done a consultation process. And as it says here, one of the clear messages from people that they consulted with was about the benefits of being in contact with each other. And so what the Department of Health did was identify 40 demonstration sites across England, half of which were peer support services and half of which were dementia advisor services, which also had an element of peer support within them. So working with the fairly substantial research team that I worked with, it was fantastic to have the opportunity to work with all 40 demonstration sites as they implemented their work over the first year or two of the National Dementia Strategy. One of the really key things about peer support, and I've put a quote by Richard Ward at the end of this slide, is what does it actually bring? And so I just wanted to include this quote from Richard. He says, "A space for collaborative meaning-making about dementia away from the imposition of medicalised definitions of the condition, which are characterised by an emphasis in deficit." It was quite interesting listening to Nan Greenwood talking there, because we did a search on the literature too. Very little, 5 studies, 6 papers, very little evidence of wide-scale qualitative work that actually looks at it from the point of view of people with dementia, who are living with dementia, and that's what I want to focus on here. I should say that these 40 services that were set up were not at all alike each other. That presented quite some challenges as a major policy-funded study. We were funded by the Department of Health as the leads for the National Dementia Strategy evaluation. So there were a very wide range of service organisational models and partnership arrangements. Some of the services were led by voluntary sector organisations, Age Concern, Alzheimer Society, but some were led by the NHS and some were led by social care organisations, and some a whole mixture. Some were located kind of within or part of pre-existing services, and others were kind of arrived more independently of what was already there. Those kind of issues actually have quite a big impact on the way the services were delivered and the sustainability of services. I'm not going to focus on that side of it at the moment, but we have just recently published issues around sustainability in the journal Health and Social Care in the Community. You will find the main report for the whole of this work on the Department of Health website, along with an executive summary and an accessible summary as well. The work around peer support, the focus on peer support, was published last year in the Purple Journal called Dementia. I'm going to give you an overview, and only an overview, given the time that I've got, of the entire evaluation. So those are the evaluation aims. I'm not going to read them out to you. We brought to the evaluation a very clear conceptual framework around social network theory, social learning theory, and self-efficacy theory. And we wanted to understand how those played out for these different services. We used a mixed methods design. We wanted both breadth and depth. We wanted to involve every single of those 40 services across the UK. But we also needed to really dig down deep, if you like, and understand what's going on here. What is it in this instance around peer support that's making a difference to people. So we had 3 different strands of data collection, and it's the last strand that I'm going to focus on in this presentation. So I will talk very briefly to the first 2, again, just so that you've got a picture of the totality. All 40 sites worked with us to give us information, provide the evaluation team with information about how many people are accessing the services, what kind of background those people had, and we used ASCOT as a social care orientated quality of life measure, which was a very interesting tool to use. We also did a series of surveys of the organisations, how they were developing, what they felt from their point of view were some of the key things, what their purposes were and how they felt they were achieving their purposes. And then we selected 8 of those 40 demonstration sites to work with us as case study sites. And we did very in-depth work in those 8 sites. Half of them dementia advisor services, half of them peer support network sites, purposefully selected to give us as much diversity as possible. And we interviewed people who were living with dementia, both people who had dementia and their family members. 101, that's one of the largest qualitative data sets of this kind. And service stakeholders, about 82 people there. The people with dementia and their family members, we interviewed each of them on up to 3 times. We also, again, used ASCOT, but also DemQual and DemQual proxy to again, get a sense of quality of life measures in there. That's what it looks like when we map it out as a mixed methods design. I'm not going to go through that with you. But essentially, a mixed methods design seeks to use a wide variety of methods of data collection so that the strengths and weaknesses of any one single method mitigate the strengths and weaknesses of another. We worked very, very closely with the people delivering the services to try and make sure that what we were asking in terms of data collection was right for what they were trying to do. So let's talk a little bit about some of the findings focused around peer support. People talked about the importance of social networks. Again, I'm not going to read every quote. You can read those there. But you can see here Jim saying, sometimes I feel a bit, sometimes I'm on my own in the house and I feel very lonely. I don't go anywhere. I don't drive anywhere or anything like that. Jim was a younger person with dementia. And his wife, Suzanne, kind of talked about there being a huge group of friends who we're both friendly with that are suffering, and obviously they're carers as well. So it's quite nice. Jim interjects, oh, it is. And she goes on, we're all thrown in the same boat, You sink or you swim. Now, I have to say, Suzanne also talked about the devastating impact that the diagnosis had had on their lives, how they felt as though they were slipping between the cracks, as she put it, and that peer support had come along at a point where they so needed that. And they actually not only gained from that, but then felt that this was a vehicle, a route through which they could give to other people. Learning from peers, that message again, first of all, the thing of the peer support is know you're not alone. So not being alone, coming out very clearly for us as well. And Judy, a carer, talking about you learn about other people's things that happen to them. You help each other out. If we look at self-efficacy, so people talked at length, lots of people talked to us about how they felt they grew in confidence, how they now chat to people. Denise is a person who has a diagnosis of dementia, and she's talking here about how her daughter has noticed that she's much more confident to go out by herself now to talk to people. Before, she'd been very reluctant to do that. Muzan was one of the support workers, peer support workers, and she reflected on what it meant, what she saw in peer support as being important. She's not reflecting on her role in peer support, but what she sees between people with dementia and between people who are actively caring. So she says, if you're caring for someone, it's all very well talking to professionals, but professionals come and go. I am conscious of that in my own life, my own working life, which is as a nurse up to this point. I've had a lot of individual casework with people, but have then moved on to other jobs. You leave people stranded. But with peer support, that's real experience that people have is shared. There's recognition of each other's needs on an emotional as well as a practical level. And many staff we spoke to and volunteers were recognising this was something quite different actually, the support between people. So if we think about the well-being of people with dementia and their carers, one of the really key things coming out of it was around timing and flexibility, around identification with others. And really underpinning all of this was about the need that people had to re-narrate their lives. A really key finding coming out of our work. People felt that peer support offered them the opportunity to find a new way of telling the story of their lives, which had been so disrupted by that diagnosis of dementia. And it gave them a route through which they found meaning, value, and purpose again. So it was something, these new social networks, that enabled them to feel socially included. Say a little bit more about re-narrating everyday life. I can't go into this in as much depth as I would wish to do so. But we know that diagnosis disrupts your sense of your biography and where it's going. So this is really, really key to people. But within this re-narration, there's now new or different interactions with services, support, and practitioners, and new or newly fashioned social networks. And people spoke to us at length about the peer support networks, the dementia advisor services, playing a crucial role in that re-narration that people were going through, giving them new structure, new routine, maintaining, developing new social networks, and giving them the opportunity to benchmark their experiences with other people. And this process of re-narration is not only helpful to those individuals, or at least an extension of its helpfulness, is actually it helped people head off problems, what we called averting problems. It's not crisis management, it's about never getting there. And that's not to say people didn't have crises, but many people talked about if it had not been for the peer support that they had, they would have ended up in a crisis situation earlier than they felt they did, or perhaps they had never got there. So they're services that were very enabling, services that supported people to maintain their independence. And they enhance self-esteem and confidence. And in that way, there's quite a parallel with some of the kind of public health initiatives about lay workers. So if I just bring this to a close, the peer support in these demonstration services was driven by being very person and relationship-centered, had a strong orientation to public health approaches. I feel still we do not locate dementia care sufficiently in a public health framework, or at least perhaps those of us who work in dementia care might talk about it as a public health issue sometimes, but the mainstream public health communities do not embrace dementia as much as I would wish them to do, and they have some useful models for us to draw on. Peer support has the potential to facilitate people and relationships focusing on social networks, information sharing, the re-narration of people's lives, and enhancing people's sense of control over their lives and control over their dementia. Thank you very much.
Thank you very much, Charlotte, for your interesting presentation. Are there any questions for Charlotte?
For your presentation. I think it's very impressive, your work also, but also the work of the volunteers that you do. I'm curious because the respondents suggest that the help from the volunteers is more enduring than the help they would get from professionals. And in literature, but also professionals stress that the problem with volunteers is that, you know, it's voluntary. They may stop at any moment in time. What do you think of that?
Yeah, no, they were not saying that. They were not saying that it was not the volunteers who were providing the peer support here, if you like. They were maybe facilitating occasions when people came together. What they were saying had the continuity was the peer, as in person with dementia to person with dementia, or family carer to family carer. It was that was enduring.
I have a question. These peer support groups, are you going to use this method, this technique, practically as a part of the implementation of the dementia strategy?
Yeah, I mean, it's in the English National Dementia Strategy.
Yes.
Yes, but it's one of the objectives.
It's a big study,
Yeah.
yes, with a lot of centers. Yes.
But it's one of the objectives of the English National Dementia Strategy from 2009. And actually, we tried very hard to find a part of the UK that did not have peer support and dementia advisors. And because it was kind of there in the strategy, even though there were the 4 demonstration sites, there are a lot of other services who are drawing on that kind of way of thinking and working. I know there's people here who have been involved in some of the services as well, and who have taken on some of that learning and moved it on into other new services now and things. So yeah, no, it's very embedded.
Very good work. Congratulations.
I was interested in having met some of the people who became volunteers, and I wondered if they've been people who were quite socially resourceful themselves. And you talked about some people on the signpost who became support. And I know there's some work being done on how social resourcefulness helps people adapt to it. And I just wondered if that came out at all.
Yeah, it did. Again, because there was so much diversity between the 40 services, they all approached that in different ways. I should also say one of the limitations of this work is that we've only spoken to people who were engaged with the services. So, you know, there will be other people for whom this wasn't the right way of getting support. So it's not for everybody. But each of the individual providers of the services recruited staff. Some had pretty much all volunteers, some had no volunteers. They were very varied.